Wonderful. Well, welcome everybody to the Children and Young People's Research Session at the International Conference. And we've got a lovely lineup of speakers for you today. I'm Paul Jarvis-Beesley. I'm from Street Games and the Social Prescribing Youth Network, and I'm co-chairing today with Marcello Berotti from the Institute of Connected Communities. Want to say hi, Marcello?
Hi.
There he is. And we've got four wonderful speakers lined up for you. And just by way of a general introduction, I just wanted to say, and it's been mentioned several times throughout the last couple of days, how important it is that we invest properly in our children and young people's future right now. It's not just because of COVID. It's been something that's been building up for some time, but I think COVID has undoubtedly exacerbated the need for us to invest properly in their education, in their job opportunities, in their health and well-being, in their general prosperity, because it is tough. It's tough being a young person at the moment. And the projects that you're going to hear about, some of the research behind it, is a really, really valuable contribution to those to that single cause, I think, that we all probably agree with, and hopefully are here to share our knowledge about. We will invite you to make your comments and questions in the chat box. So please do that. This is a great opportunity to learn and share from each other, share any thoughts, any links, and people will snap those up for sure. But I think from our perspective, from within the Social Prescribing Youth Network, it is, in a sense, I think we felt a few years ago that children and people may have been overlooked in this wonderful social prescribing movement, but we're working hard to redress that, and the balance is shifting. There is a lot more activity up and running now than perhaps there has been in the past, and it's really exciting stuff. And we saw the awards last night, if you were there, some great projects illustrated there. And I think what they all have in common is this the need to connect young people who feel disconnected for whatever that reason might be. Young people who've become disconnected from sources of help in their local community. And the whole purpose of all of our work in this area is just to reconnect them and make sure that support gets them at a time and a place when they most need it. So I'm going to stop there, and I'm going to start to introduce our I'm going to pass to Marcello, who's going to introduce our first wonderful speaker. So over to you, Marcello.
I thought you were going to steal my bit there. Hi, Marcello Berotti from University of East London. I'll introduce the first speaker, who's Gloria. Cheung for pronunciation, from the University of York, and she will be presenting about the impact of COVID on social prescribing, impact of COVID in CAMHS, inpatient mental health units. For those who are from abroad and might not know what CAMHS is the Children and Adolescent Mental Health Service, and is part of the English or UK NHS, the National Health Service. So I'll just pass it on to Gloria for her presentation. Over to you, Gloria.
Hi everyone. Thank you for inviting me to accepting my presentation. I think my presentation is just uploading again, so it might just take a little bit before I can start presenting. So sorry about that.
It's okay. We can wait a little bit longer. Maybe I can remind attendants to be on mute, and each of the presentation will take about 6 minutes, and then about is on. So I'll let you go now.
Thank you. So hi everyone, I'm Gloria, and I'm currently a medical student, and I'm really interested in child mental health. And today I'll be talking about our study on the impact of COVID-19 lockdown on social prescribing in CAMHS inpatient units. So, as we know, social prescribing came about as we recognize how important social and environmental factors are on one's health. These activities are usually at a low cost and can be personalized based on patients' needs. And this has become increasingly popular in CAMHS. In inpatient CAMHS, these activities ranges from shopping trips to pet therapy and gardening groups. They can help young people feel less isolated from the outside world as they're able to leave the unit and do these activities. This in turn helps them adapt to the outside world when they are discharged, as they feel more connected to the outside world while being an inpatient. Social prescribing also helps strengthen their support network as they interact with those with similar experiences. This could help reduce their length of stay and increase capacity of CAMHS. However, due to COVID-19 lockdown, many of these social prescribing activities have been modified or cancelled. Hence, our study aims to investigate the impact of COVID-19 lockdown on social prescribing in CAMHS inpatient unit. We sent out an online survey to 18 CAMHS inpatient units across the UK. We compiled a list of common social prescribing activities and components of improvement in young people to measure the effectiveness of these activities. Most questions were set using a Likert scale, while others were set with a free box from comments for qualitative data. Overall, social prescribing activities have been reduced during COVID-19 lockdown, with 55% of participants describing a reduction of more than 50%. 50% of responses indicated that specific social prescribing activities were completely stopped during lockdown, with day trips and places of interest being the most affected. When asked about how social prescribing benefit patients in CAMHS inpatient wards, a score of 4.03, with 5 being the most improvement, was obtained on average for all components of improvement, with social skills and anger being improved the most. However, due to COVID-19 lockdown, 74% described a decrease in effectiveness of these activities. The average impact score was 3.74, with 5 being the most significant impact. The most affected components are emotional well-being and anger. Provision of social prescribing activities has also changed due to COVID-19 lockdown. 94% indicated that most activities has been changed to being provided by ward staff and being ward-based, while 6% indicated that activities were switched to online provision. And due to the change in provision, 67% indicated a decrease in effectiveness of these activities. We asked participants what they believe the most crucial component of social prescribing is. We identified 2 key themes: socializing and being able to leave the unit. These 2 themes are linked to each other. Being able to leave the unit means young people can spend more time with others, and sometimes it could include their family members as well. We identified 3 key challenges participants have found around provisions of activities. Due to COVID-19 lockdown, young people are isolated from the outside world, which could include their family members and friends. This in turn decreases the motivation for young people to join in the activities, as socializing is a crucial component of social prescribing activities. This could then lead to boredom. Young people are less distracted from their intrusive thoughts, which would increase the incidence of self-harming behaviors. There are 2 things participants would like to see regarding provision of social prescribing activities during COVID-19 lockdown. Participants wish to see less restrictions in the wards. Outdoor activities should also be allowed, as all young people in the ward should be considered a single unit. Participants also wish to see a wider range of inpatient-based activities. They would like to have more staff in the wards and creation of more online activities. In conclusion, our study showed that social prescribing is crucial in inpatient CAMHS. COVID-19 lockdown has removed the important components of social prescribing activities. As most restrictions have now been uplifted, inpatient units should start increasing the provision of social prescribing to help improve patients' mental well-being. It is therefore important to develop a suite of resources and interventions that can be employed in the future to mitigate against disruption to patient treatment. Thank you for listening in, and I hope you enjoyed my presentation.
Thank you, Gloria. I just have a quick look through the chat. I don't think there is any question, unless I'm in the wrong place with the chat. But I'm going to ask a question, or two maybe even. I was going to ask, first of all, well, thank you for the presentation. It's quite interesting, and obviously it looks as if, well, obviously COVID has had quite a negative influence on the patients and people, young people. I was going to ask you one very quick question. What kind of young people are we talking about? I mean, what kind of age range, and maybe what kind of problems do they have exactly? That's one question. Then the other question was about link worker. Did you have a link worker as part of this social prescribing scheme, or is it something more kind of less structured, shall we say? Let's stop there with the questions, otherwise, yeah.
Yeah, that's all right. I think it really depends, because actually we recruited, like, as I've mentioned, I think 18 inpatient units. And I think all the units might be a bit different, because some might be like focused on learning disability, some might be focused on forensic. But I think the definition of young people here should be under 18, because I think in CAMHS, all young people should be under 18. And when they're over 18, they will be transferred to adult inpatient unit. So that will be sort of the age range for the young people. And for your second question, you mentioned link. Is it the link worker?
Yeah. Because in most of the social prescribing scheme, at least recent social prescribing scheme in the last few years, there is kind of a link worker who acts as a link between primary care and the voluntary sector normally. I was wondering whether you had such a role as part of this support to young people in CAMHS units.
I think, again, this depends on the wards. So I've heard that some inpatient units do have a social prescribing lead to prescribe these activities. And currently, I am actually shadowing some psychiatrist in an inpatient ward CAMHS unit. And for them, they don't actually have a social prescribing lead. So instead, they have some occupational therapist that would provide these activities for inpatients. And these inpatients can choose whether they want to join it or not. So these are more unstructured, I would say. And it also really just depends on the unit and the funding, obviously.
Thank you.
Wonderful. Thanks so much, Gloria. If you could stop sharing your screen now, that would be fabulous while I introduce our next speaker. And thank you for setting such an amazing example of keeping perfectly to time as well. That was quite exceptional.
Sorry, I just need to quickly see how I can unshare my screen.
Okay.
Okay, found it.
You got it. Okay, thank you. So our next speaker is Julie McCarthy from Greater Manchester, who's going to talk to us about a children and young people social prescribing scheme that she has underway in Greater Manchester. For those of you who haven't met Julie before, she is a complete unstoppable force in Greater Manchester. It's just extraordinary what Julie has managed to get going. Yeah, woe betide you for trying to get in Julie's way. Don't do that. But it is absolutely wonderful. We've been very fortunate and privileged to be sort of involved in this project with Julie, so I'm really excited to hear some more about it as well. But over to you, Julie.
Thank you, and thank you for that introduction. Okay, I'm going to try and share my screen now. Let's see, does it work? Yeah, is that all? Is that okay? Brilliant. First of all, I'd like to start with an apology. Always a good way to start a presentation. I did want to talk to you about not only the pilot that we've been doing with colleges in Greater Manchester, but also an upcoming pilot that we're going to be doing in schools as part of Be Well, which is an incredibly exciting opportunity, but I'm not allowed to talk about it because the mayor's announcing it on Monday and it's embargoed. So that's all I can say about it. Otherwise, I will be taken out and my teeth pulled out or something. So I will only be talking about the one pilot. But just to say that to put this in context, I lead on a program called Live Well, which is a beyond social prescribing initiative. It's part of the Mayor's manifesto in Greater Andy Burnham's manifesto. I work across health and social care and Greater Manchester Combined Authority, and we are going to be looking at holistic approaches and community-based and co-produced approaches to sort of a beyond social prescribing ecosystem across Greater Manchester. So this is something I think we're going to have a huge amount of developments happening in Greater Manchester, and including a focus on children and young people, which is one of Andy Burnham's priorities. So a lot more is going to be coming out of Greater Manchester in the future. So okay, so where we started with work with children and young people, and this is very early days, and we don't have a lot of data, we don't have a lot of evaluation of this program, but we have some. So that's what I'm going to talk about, where it's come from mostly, and then what we are finding out, what we're discovering. So where this program comes from, obviously, is from really a consideration of the Thrive model. So that is the model developed by it's the Thrive Framework for System Change, developed by the Freud Centre and others, a member of whom is on the call today. And it's an integrated, person-centred and needs-led approach to delivering mental health services for children, young people and their families. And it replaced the old kind of stepped model. And where we're looking at with social prescribing is in those two quadrants, really, of quintiles. I think there's 5 of them. So getting advice and getting help. So that's where we really see the role for social prescribing. So we're looking at those two top needs-based groups. So typically, a young person in the getting advice segment would be adjusting to some life circumstances, for example, with some mild and potentially temporary difficulties. And the kind of interventions that are favoured here would be community interventions, so typically social prescribing. You might also find young people here who have chronic or ongoing difficulties, or who are managing long-term conditions themselves. So that really resonates with the whole social prescribing approach. I think it's very important, before I continue as well, to say that obviously we can term this social prescribing, these approaches as social prescribing, but obviously we've got voluntary sector organisations that have been doing something which you would recognise as social prescribing for a very long time. So I think we have to be careful not to kind of medicalise or jump on other people's approaches when this work has been happening for a very long time. It's very useful to frame this as social prescribing, though, for a number of reasons, strategic and funding reasons. But we can see a real resonance between a social prescribing approach and the Thrive framework. Okay, so the ideas, the principles around Thrive. It's a shared language. It's needs-led rather than diagnostic. It's about shared decision making, proactive prevention and promotion, partnership working. It's informed by outcomes. It's about reducing stigma around mental health and well-being. It's about making mental health everyone's business, and it's about making services and access to services truly accessible to children and young people. So again, really resonates with social prescribing. So why did we decide to work with colleges? We decided to work with colleges, and why did I get involved in the pilot that the Association of Colleges and Street Games were running? Because young people between the ages of 16 and 19 still fall off a cliff edge in terms of their mental health and well-being. Although all local authorities and all localities have a statutory duty to provide services for 16 to 18-year-olds, often young people, by the time they get to the top of a waiting list, they've reached 18 and then they're into adult services. So, and we also know that young people do not access services by ringing up a phone line, a doctor's surgery, and waiting for 10 minutes or even half an hour to get through. They need hyperlocal services in the places where they are. They need low thresholds for access. They need short waiting times, and they need broad choice. They need things for them where they are, and they need choice about what those things are. And we know that colleges have staff that enjoy really good positive relationships with young people. So that's from teachers to pastoral teams. And we also know that colleges already have enrichment programs, some of them really extensive enrichment programs. So that would be in school, you'd call it an after school club, for example. And there's a potential to expand that offer and also expand the links that that offer has with local communities. And you might think that a college would have really strong links with what's going on around them. That's not true. So, for example, one college we're working with, there's a major young people's theatre with a substantial nationally recognised mental health and wellbeing programme, and the pastoral lead for the college didn't know what the building was, and you can see it from the college. So that for me is quite extraordinary. So we have to go do away with a lot of presumptions and a lot of assumptions.
I'm sorry to be a very boring time bore, but I'm going to have to nudge you along a little bit, if you don't mind.
Oh, have I done 6 minutes already?
Yeah, you just gone over, I know. It's crazy, isn't it?
That's not like me at all. Right, okay, I'll go really fast. So what we've noticed in colleges is, what we found out already is that young people have frustration and disappointment with the mental health services that are available for young people. A lot of the young people who are seeking support are actually already known to mental health services, but they're on waiting lists. They don't know what's available to them around them in terms of a kind of social prescribing community offer, and they're really not sure what they might be interested in. The support that they most find valuable is often around being around like-minded people in a safe environment and exploring their identities. It's about growing in confidence and improving social skills, meeting other people. There is a lot of isolation, particularly post-COVID. And the use of the introduction of a link worker in a college has had a dramatic effect on both the college staff's ability to work with young people and the young people's ability to access services and support. So these are the kinds of outcomes that we're starting to see: young people getting support when and where they need it, starting to build on assets in local communities, so accessing skilled staff in the community as well as upskilling people in those organisations. So, for example, your local theatre, your library, your local VCSE organisation. Creating better pathways for support and advice, including with mental health services, looking at more high level need. Young people are getting referred quicker, so more appropriate, faster referrals, and staff feel more skilled to support students. How are we evidence? Something that we've developed with Greater Manchester I Thrive. It's actually intended for arts activity, but it's actually universally applicable. We've created an evaluation kit, mostly for the voluntary sector. It's an adaptable method. It uses ONS4 and short webs, and it enables an organisation that is not used to collecting this sort of data to put it into a spreadsheet and to create reports so that they can same kind of evidence as a clinical approach might do. Blocks. For us, that unblocks access for the voluntary sector, for example, to provide these kinds of services. I'll stop there. I'm terribly sorry I went over.
When I said you were an unstoppable force at the start, I didn't know quite how true my words would be. So it was my fault. Thanks, Julie. That was that was fantastic, and thanks for speeding up at the end there. Much appreciated. We will take more questions at the end for all the speakers. So if you thought of something from Gloria's that you'd like to put in the chat box, please do that. Julia, just one quick one for me. The title of this conference was Triumphs and Tribulations, and we often overlook the tribulations, the things that don't quite go according to plan, and it's really important that we learn from that stuff, and especially around children and young people, social prescribing. It's a new area. If there was one thing that you would say was your biggest challenge when setting all of this up, what would it be, very, very briefly?
First of all, I'd say I didn't set all of this up because I think Dawn's on the call as well, and I wouldn't want to. I need to name check her. I think the biggest thing for us, the biggest tribulation was about capacity, particularly with college staff at this time, because they're very short staffed. They've got a huge amount of need, and the thing that has helped us most is how. So we only have a link worker in one college. Extra funding, and that's in Rochdale, but she has made a difference, and we're about to appoint another link worker in Salford. Salford are going to match fund that, so we can put someone in place for 18 months. So I would say capacity of staff. They have a huge willingness to get this right, but they just do not have enough hours in the day.
Absolutely, thank you. So what some other people might call case loading as well. I think that's such a big issue in this area. So probably one that we need to pick up. Thank you, Ruth. I've seen you've posed a question there. We will pick that one up at the end. Thank you. So please do keep popping those in. We will monitor the chat box as we go. Julie, if you could stop sharing now while I introduce Georgina, the wonderful Georgina, who's going to talk to us about just a simply wonderful project called Lullaby, which completely stole the show at last year's international conference when we had this amazing presentation from New York. And we thought, gosh, how amazing, what wonderful things going on in New York with Lullaby. And guess what? It's now here in Liverpool. And Georgina is going to tell us all about it. When I say here, I know this is also an international conference here in the UK where I am. So in Liverpool, and Georgina's going to tell us all about it. Over to you, Georgina.
Thank you so much, Paul. My PowerPoint is just loading, so if you give me a few seconds.
Well, can you sing us a song while we're waiting, or?
Yes, I've got a bit of music actually to introduce you to, but so I'll leave that.
Okay.
I could quickly go and get my cello, but I think my PowerPoint is about to load now.
All right, good.
Sorry, it's taking nearly there.
Yeah, it's going. Yeah.
Yeah, good to go.
Great. So thank you so much for having me today. I'm Georgina Aasgaard, and I've had a fantastic opportunity to be involved in the Lullaby project through Live Music Now, both as a musician and as a researcher. Live Music Now is a national charity delivering social impact through music, which involves new social prescribing strands, such as the Lullaby project. Live Music Now launched the Lullaby project last November in Cheshire and Merseyside and was inspired by an initiative which started 10 years ago in New York at the Carnegie Hall's Vail Music Institute. It's a songwriting project pairing pregnant women and new mothers with professional musicians to write, record and perform lullabies for their babies, to support maternal health, childhood development and family bonding. It's a pilot partnership between Live Music Now and NHS services, reaching out to a variety of social prescribing models, and which is now part of the international lullaby community, which has spread across 20 different countries. The aim of the project is to assist the NHS early intervention and prevention agenda to improve perinatal mental health and reduce health inequalities by offering nuanced emotional support to vulnerable mothers through the simplicity of a lullaby. It also aims to improve parental confidence and advocacy by promoting creativity in healthcare. Following the launch of the project in November, we keep exploring new methods of delivery, which include both online and in-person sessions. These can be planned as one-to-one sessions or group activities. But most importantly, the Lullaby project is about listening and tuning into the needs of each mother to encourage them to write something that is meaningful and personal. In order to do this, we use a lullaby journal, which contains prompts such as writing a letter to your child in which moms can express feelings of love and hope. These prompts offer a simple way to write lyrics. Musicians will then support the melody making by improvising around the mom's musical tastes, and the resulting songs are then performed and recorded, creating an intimate and personal keepsake. And I will now put it into context and introduce you to Victoria, a mom I've been working with for 5 weeks. She was nervous at first. She said she couldn't sing, but she ended up recording her song in the studio and has now joined a choir. Her lullaby is called Sweet Baby Molly. Her wish was to include different languages and have a taster of the Pachelbel canon because it was played on her wedding day. So this is just a little glimpse. Sweet dreams, sweet Molly, todo dulce, mon amor, duerme tranquila, mi niña, dormi bene, mia piccola. Ending our journey together in the recording studio was just wonderful and so meaningful. By adopting the role of musician as researcher and working in partnership with Dr. Carrie Wilson from Liverpool John Moores University, I designed reflective diaries, context-specific feedback methods, and conducted interviews with both participants and musicians based on the PERMA scale. PERMA stands for positive emotion, engagement, relationship, meaning, and achievement. We are just at the start of our research journey, and these are the findings we have so far, starting with hearing the participants' voice. The Lullaby project gives an opportunity for moms to talk about things that they might struggle with, or just to celebrate what's happening in their journey. I have felt so engaged. It's something that's so personal and unique to my family, something I can have forever, and I've learned that I can do more than I give myself credit for. This quote clearly illustrates positive emotions, engagement, relationship, meaning, achievement. Participants gained self-esteem, confidence, and ownership through the achievement of writing a song. We found that the children, by engaging with musical routines and repetition, enabling them to recognize their songs, and a non-hierarchical and non-judgmental environment created by the musicians established a sense of trust in which co-production and shared creativity was celebrated. Mental ill health during pregnancy and in the first year after birth affects 1 in 5 women, and the cost is considerable. I believe that the partnership between Live Music Now and the NHS has great potential to support maternal mental health and needs to be implemented in social prescribing networks. This quote from a participant sums it all up. Your traditional route of therapy is not for everybody. Some people need different outlets. Using the voice, creative writing and music to express how you're feeling about your child is so powerful and incredible. The outcome has been phenomenal, and you can't do that with traditional means. So to finish with, and in case you sometimes struggle to fall asleep, please feel free to listen to our lullabies, and why not start creating your own, as all our participants said how simple the process was. Thank you very much.
Wow. Thank you, Georgina. I don't think there was a dry eye in the session in the middle of that. That was very, very powerful. Thank you for sharing that. And again, wonderful for the keeping to time. Thank you for that. There are a couple of questions for you. One is from Lisa, who says, I know that it's based in Liverpool. Wonder if it could be offered to those outside of the area, even in an online format. And she concludes with, I love this, which I think we all do. So any thoughts on that?
Yes, we have started spreading across through live music. So Live Music Now is a national charity. So I'm actually supervising and mentoring the Lullaby project in Wales. We have 3 projects at the moment going. One is in the Tona Hospital, which is a mental health maternal unit, and we've got also the project starting in community centres. There's been a fantastic initiative delivered in prison with the Lullaby method, and I'm also kind of launching it in at Alder Hess Children's Hospital where I work, at the Dowie Jones unit, which is the inpatient unit for children. And I think it's a method which can definitely be spread across, and which has already started spreading across the UK.
Wonderful, thank you. When you get to look at the chat, you'll see there's lots of very appreciative comments in there. Just one quick one from me. How, generally speaking, would mothers find their way to Lullaby? How do most people hear about it?
So on Merseyside, we've been supported by a wonderful woman called Keely, who works for Improving Me and for women's creative health on Cheshire and Merseyside. So we've had kind of a key person, but Live Music Now has worked very hard behind the scenes to make those connections. Some of our mums actually were referred through like breastfeeding groups. We've had some mums who've been referred by through pages on Facebook. At the moment, I've just started a new Lullaby project, which is very excited, with a group of Sudanese women based in Toxteth in Liverpool. And these women have been referred by a wonderful woman called Banin, who works for the Sudanese community in L8, and who's referred 8 mothers who have English as a second language. So we are now also exploring the Lullaby with women who don't have English as a first language. Fantastic. Which is very exciting.
Very exciting. Well, more power to your cello elbow. Fantastic. Thanks so much.
Thank you very much.
And stay on the line if you would for any more further questions at the end. That would be great. I'm going to pass back to Marcello now to introduce Dan.
Thank you, Paul. The next speaker is Dan Hayes, who works for Anna Freud Center and also UCL. And he will talk to us about barriers and facilitator to social prescribing for youth mental health, and particularly the interviews around with link worker, and using the theoretical domains framework, which is well, he will explain it better than I can. So I'll leave it to Dan.
Thanks. I'll just load up the screen and apologise in advance. I'm on day 3 or 4 of COVID, so if I have a coughing fit, I will try and put myself on mute for a second, but I'm not 100% at the moment.
Thank you for joining us anyway.
Are you able to see this?
Yep. Yeah.
Okay, so yeah, thanks for the introduction, Marcello. As outlined, I'm Dan. I'm a senior research fellow at UCL and the Anna Freud Center, and my background broadly is in research with young people in the broad topic area of person-centered care, so shared decision making, social prescribing, things like that. So just to set the scene for the research that we were doing, me and some colleagues conducted a review back in 2019 to look at the area of social prescribing for children and young people using the link worker approach. We were quite aware that it was dominant in adult settings and older adult settings in particular. So we knew that there was a kind of activities that could be used by young people, but whether it was being implemented yet was kind of an unknown for us. So we did this big scoping review, looked through thousands of papers, and there was no evidence in the published literature around social prescribing for young people. And there were a few different reasons that we came up with for this. Maybe it was just too new. But also through the Youth Social Prescribing Network, we were talking to individuals who were trying to set up social prescribing with children and young people, and anecdotally saying they were running into differences. So we thought that we would put into a bid, which was funded by Emerging Minds, which we're really grateful for, to really explore what are the barriers to the link worker social prescribing approach with children and young people. And we chose to focus on the link worker approach because that was the dominant approach at the time, and how NHS England or equivalent were rolling it out at the time to work with young people. So the method that we used, we interviewed some link workers and individuals involved in social prescribing organisations, and wanted to understand what the barriers and facilitators were when working with and setting up social prescribing for children and young people. This did have a mental health focus, but I think a lot of the findings could be applicable to children and young people more generally. And the interviews and analysis were structured around something called the theoretical domains framework. And this is a behaviour change methodology which looks at how we can influence behaviour through 14 key different constructs, and they're split into 3 overarching areas, which are capability, opportunity, and motivation. And an example of capability would be somebody's knowledge or skills, and opportunity would be the environment, for example. So there's obviously 14 domains. There's far too much to talk about in one go. So I'm just going to give you a snapshot of some of the findings that we've highlighted. So in terms of capability, a lot of individuals and organisations felt unsure about how to implement models of social prescribing with children and young people. And at the time, this was due to a lack of guidelines, protocols, or detailed examples of best practice. So they felt a lot of the time they were just shooting in the dark and not knowing how to set this up in terms of governance, procedures, pathways, etc. And for link workers, it was outlined that training varied quite a lot when working with young people, and particularly young people with mental health difficulties. Some didn't receive any training on this whatsoever, and were then expected to work with these groups. And training really around mental health tended to focus on safeguarding more than anything else. There was also discussions around having to manage complex relationships, such as when there were differences or discord between parents and young people, which was never really touched upon, and they had to navigate themselves. Link workers also said that they were the ones often having to scope out available services to socially prescribe to, and that there was a lot of churn within these services, so it was a constant struggle to try and keep updated on these. In terms of opportunity, transport came up as a kind of a key issue for rural communities. If the social prescribing activity was after school, but not in the school, and the parents were at work, how would the young person get there? So we have to think about location as an important factor within this. For link workers, a space in particular where young people felt comfortable to discuss their values, preferences, and options was needed. And this was not often available, and then young people felt kind of uncomfortable discussing certain topics. So the emphasis is on a safe space for the young people. Due to prescribing or commissioning models, some link workers could only socially prescribe with children and young people of certain ages. So an example given to me was there was a family that came in, but due to the limitations on funding, the link worker could work with the 14-year-old brother, but not the 11-year-old. And this caused obviously some friction. Other things that popped out were that being part of a multidisciplinary team for link workers was important. A lot of the time they felt quite isolated, and as outlined in other presentations and throughout the conference, social prescribing shouldn't just be seen as its own thing. It can be seen as its own thing, but it's addressing the social determinants of health, and a more well-rounded approach, but as part of a wider multidisciplinary team, was thought to be beneficial, as well as setting up other link worker and link worker networks so that they could converse. A lot of the time there was only one link worker in this CAMHS team, for example. And as touched on in the earlier presentation, supervision was varied and often inadequate, and often there was not a lot of clinical supervision for people, for link workers working with vulnerable young people. In terms of motivation, link workers and organisations often discussed that sometimes there was a lack of options or socially prescribed activities which wouldn't really fit with the values and preferences of the young person. And in this instance, would social prescribing be an appropriate avenue to pursue? They also discussed a lot of positives, but a negative consequence that came up was the blurring of boundaries when working with young people around when they were accessible, like such as in the evenings, should they talk to them then? And also once they'd established this relationship with them and then passing them on or supporting them to that socially prescribed activity, managing the endings, which was never discussed and often quite cut short and brutal. Most felt optimistic about the benefits of social prescribing as well, but some felt uneasy as it being pushed as an alternative rather than it being in conjunction with other services. Just in terms of next steps, we are writing these findings up along with some concrete recommendations based on behaviour change methodology underpinned by theory and practice to better facilitate social prescribing with children and young people. And alongside this, we're currently setting up a couple of projects. One is called Inspire, and that's where we're co-developing and evaluating social prescribing pathways for young people in CAMHS on waiting lists. And we are currently looking for sites. So if you are interested, do email me about this. And a slightly long one in the pipeline is working in social prescribing in schools, mainly to address loneliness. I'm going to stop there and just say we're also just updating a review on the evidence base. So if you've got any reports or anything that you want to send over that you might want to include, my email address is in the slides, and feel free to contact me with any queries or questions. Thanks.
Thank you, Dan. Very interesting, quite robust. And I can recognize loads of different challenges to improve the work of link workers, challenges that we picked up on our evaluation. We did some years ago with the street games. There is a question, just one question, then maybe we can open up to the more general Q&A, but more specific question from Justina, I think is pronounced, apologies. Sorry, you're on the camera as well. Sorry. Did you have any London-based service evaluated as part of your work?
Yes, we did.
Okay. Okay. Yeah. I've got. I mean, I don't know if we want to open up to more general Q&A, Paul, at this stage.
Yeah, super. And I was going to say, if people, as we're, I think we're about sort of 40 or so people in the group. So if you want to, if you prefer to give your question verbally rather than typing it in, it would be lovely to hear from you. Just use the hand up sign, which you'll find under the reactions button. Just use that. That will bring you up to the top of the screen, and we will see you and invite you to unmute and talk to us. Just while people are thinking about that, what I'd like to do is maybe just go back to all our speakers and perhaps put the same question that I put to Julie, which is just echoing the title of the conference, which is Triumphs and Tribulations. And we're recognizing that, we're somewhere down the road with social prescribing now, which is, rooted in goes back decades, really, the origins of social prescribing, as I think Julie was referring to in her presentation as well, that this has a long-rooted history in the voluntary sector. But we're trying new things, aren't we? And sometimes things don't go to plan, and sometimes we try to not hide them, but we overlook them in the hope of focusing on the good stuff. But I'd just like to invite everybody, all our speakers, just to reflect perhaps one or two of the tribulations they may have faced in either their research or their projects, some of the things that didn't go so well, because they are good sources of learning. Gloria, I'll come to you first, if that's all right. Any thoughts on that?
I think one of the main challenge I have in my research, I think we only have like around 30-something respondents. I think it was quite challenging just to get people to do the survey. We've emailed like trust all over. We email like Inpatient the country. I to call them and everything, but sometimes it's really hard to get response sometimes, and there is just nothing I could have done more to have improved on that, I think.
That's a really interesting one. I'm sure that will echo with many people here. And did you stick to under that circumstance? Did you stick to the rigor of your original research plan, or did you need to adjust in order to make it easier for people to access, or how did you approach that?
I don't think we really adjusted much because it's online survey anyways.
Okay.
We didn't do like a paper one. So yeah, there's not much adjustment we did. So it's just how it is, I think.
Sure. Understood. Thank you. Georgina, any reflections from Lullaby on tribulations or challenges?
I think the main challenges have been to kind of get the timing of things and get everybody together, and for the projects. And I think we really need to think collectively and work much more together. So by the time we get the musicians' availability, the organizations on board, finding out spaces to bring the women together, it's a huge amount of logistics. And I think we have a lot of improvement to do in communicating with each other and really understand each of our individual roles. I think this is very important to try to improve this logistic aspect of referring the people, and also making sure we don't do wrong referrals. So I think it's very important that we, generally speaking, communicate much more with each other, between musicians, between researchers, between organizations, and between health organizations who have this incredible potential to make the referrals, and who are not always, able to do them because of this lack of communication between all parties.
Thank you. That's really really clear, and a good, open and honest reflection. I'm just going to go back to there was a comment earlier from Leona, and this might be for Julie and Gloria. Dan, I'm sparing you at the moment because I really appreciate what you've done for us today and come along on your almost off your sick bed to get here. So I will spare you, but do feel free to pop in if you feel able to. But this comment from Leona for, I think, Julie and first, and perhaps Gloria to reflect on. It was, I think, in response to something you both reflected on, which was, I'll just read the comment. She was talking about the work that you were doing with young people and saying the waiting list for support is long, and the duration of the mental health support is not always long enough. I wonder if that chimes with you, Julie, and then I'll come to you, Gloria.
Yeah, absolutely. As I mentioned in the presentation, a large majority of the young people who are either presenting themselves or who pastoral teams are kind of referring into a sort of social prescribing offer are already known to CAMHS, and they're on a waiting list, or they're not getting what they think they need, or they're just getting a very short spurt of it. So yes, absolutely. And this isn't obviously instead of intensive psychological support through CAMHS, but it can be part of waiting well, but it's also part of an early intervention strategy. You would hope to see that waiting lists, that things don't escalate, and so that those waiting lists get shorter, but that takes years to work its way through the system. But absolutely does chime with me, yeah.
And in Greater Manchester, excuse my ignorance, in Greater Manchester, is there a single CAMHS service, or is it split across several boroughs?
No, so we've got 10 localities and they each have their own services.
Is it a situation where some of the waiting lists are longer than others, without naming names? I mean, are there any thoughts about why that happens?
I think I couldn't tell you exactly, but my intuition, and also having my own child who's accessed CAMHS services, waiting lists are universally long. I used to work for a mental health organisation in Greater Manchester, actually, 2nd Street, which is a voluntary sector organisation, and they are constantly being commissioned to reduce waiting lists, because CAMHS can't cope with the influx. And post-COVID, that situation has only got worse. We know that there is a huge crisis in particularly the schools, which is why we're doing a schools pilot. There's a huge crisis in schools with mental health of pupils, and CAMHS are not set up to deal with that crisis.
Thank you. Gloria, any thoughts from your side on these points about the waiting list and the length of support that's then available?
I definitely agree. The waiting list is definitely really long at the inpatient unit I sort of like volunteer in. And like, I think because I'm currently in York, the inpatient unit I'm working in specializes in like eating disorder. And it covers a really large area, including like people from Hull will come in. So I think because as well, young people who are already in the inpatient unit, it can be sometimes really hard to get them out of the inpatient unit because they're really used to it. And I think social prescribing would help if they could help, if there's more social prescribing activities, if they could help adapt the young people better to the outside sort of environment, it might help reduce the length of stay. And yeah, I think that's why the waiting list is really long, I think.
Thanks, Gloria.
Could I ask Paul? Sorry,
go on, Marcello, yeah.
To ask Gloria something. It's troubling me. I mean, when young people go outside, because you said that it's beneficial for them to go outside and attend outside activities outside the unit. Is this presumably this is organized with somebody? And somebody who can take them out to these activities. Is that kind of support service something that could be perhaps strengthened maybe, so that people have more chances to go out, and then more chances to then improve perhaps, and then get out of the unit altogether?
I think that's definitely true, because I think at the minute it's only people who are like working in the unit, like occupational therapists, that would bring the young people out of the unit. And I think for some activities, I think there was like a music group I attended. I think the therapist wasn't even able to come in because of COVID restrictions, and they can only still do it online, which I'm really not sure why, because I feel like COVID is sort of dying down a little bit. I feel like there could be some negotiation space for people to come in a bit more in order to get young people out of the unit a bit more to attend these activities.
Thank you,
Gloria. I just we've got a couple of minutes left. I just wanted to bring in, we've got an expert sitting in the wings here, Dawn Mitchell, who's part of the Social Prescribing Youth Network and possibly knows more about social prescribing for young people in the field than anyone else, having been around so many different projects. Dawn, one of the interesting things that's being talked about here is the relationship between CAMHS and social prescribing, and I know that's been a topic that you've come across quite a bit in your travels around different projects. So just wanted, we've literally only got a couple of minutes, but just some reflections on how those two interact and interrelate.
Afternoon, everyone. Thanks for that, Paul. I thought you were going to say because I've been around so long. And no, yeah. So the relationship with CAMHS is really interesting, and I'm so pleased that Daniel and the team are doing some further research around this. What we've seen is the opportunity to use social prescribing, how we describe it, is kind of a step up and step down approach. So it almost becomes like a wraparound support around the CAMHS intervention. So rather than a young person having the therapeutic intervention through CAMHS and then just being told, you know, off you go, good luck out there, come back if you need us, and creating this revolving door situation, that actually there's a step down approach where a link worker can come in and say to the young person, okay, so is this a good time for you to now build these community connections and stay healthy and happy, and be connected into the community? So that's kind of the step down approach. And then there's an opportunity, when we've talked about waiting lists, for young people who may have been escalated into a CAMHS waiting list to actually get support while they're on the waiting list. And for those of you who've heard me talk before, you probably have heard me use this quote, but we've got a brilliant quote from a young lad who said, you know, if someone had just bought me a pair of football boots a couple of years ago, I probably wouldn't have needed to go through that CAMHS intervention. And you know, there's been a lot of talk over the last couple of days about loneliness and the loneliness agenda. And a lot of what our young people are experiencing is social isolation and loneliness, and 16 to 24-year-olds report as the loneliest in our populations. So I think it's incredibly important that we try and, like Julie was saying, demedicalise, you know, find these community solutions for young people so that they don't end up going down an over-clinicalised or medicalised or medicine-based intervention when we know that there's a huge potential for social recovery. Oh, you're on mute,
Classic,
Paul.
classic. I wait till right to the end to mute myself and then not manage to unmute. Thank you, Dawn. That's a really helpful point on which to close our session. There's been some fantastic comments in the chat, so I hope everybody's had a chance to look at those. Thank you all for joining. If you want to discuss this further, please do pop into the AirMeet networking lounge. There is a table there where Dora and I will be, I think, in the break for the Social Prescribing Youth Network. So do come and have a chat with us there, either before the next session, or I think there's a break as well after the next session. But there's a 10-minute break now, and then further breakout sessions on your program. So enjoy the rest of your afternoon, and also have a super weekend. Thank you, everybody.
Take care.
Thank
to our
you.
main speakers. Bye.
Thank you. Bye-bye.
Thanks.